Is that my first slide, Rachel? Yes, okay. So the World Health Organization has defined obesity as a BMI of 30 to 34.9 is class 1, class 2 is 35 to 39.9, and class 3 is greater than 40 or greater. In my opinion, this classification should be expanded because it is not unusual now that we're seeing patients with BMIs of 60 to 70 deliver every week. Usually it's 3 to 5 patients a week now. You can also, people who are greater than 50, sometimes you'll hear them referred to as super obese. Next slide. So South Carolina, again, is one of the most obese states in the country. The lower line is the United States, and the upper line is South Carolina. So we're anywhere from 7 to 10%, depending on the year, more obese than the rest of the country. Next slide. If you look at obesity based on race, the green line represents Blacks, the yellow line represents Hispanics, and the purple line represents whites. So all races have increased over the years, but the race with the most obesity is Black Americans. Next slide, please. So obesity is actually a disease that you find in the low-income groups. So the blue line at the top is the rate of obesity in people who make less than $25,000, households with less than $25,000. The green line is between 25 and 50,000. The purple line is 50 to 75,000. And the yellow line is individuals that make greater than $75,000. Now, this is, next slide, please. The next slide is education. The blue line represents the, if you didn't finish high school. The green line represents if you finished high school. The purple line represents if you have some college classes, and the yellow line represents if you have a college degree. So in summary, South Carolina is again one of the leaders in the country regarding this, and it tends to be collated in areas that have low education and high poverty levels. And unfortunately, individuals in South Carolina who are Black, I mean, I don't think it has anything to do with the color of their skin as much as I do think that it's part of the social determinants of health. People truly live in food deserts. And I remember talking to an individual in Florence who was a diabetic. And I was telling her, you know, you need to eat more protein. And we were going through it. And she said, Dr. Johnson, my household can't afford protein to eat. And so, you know, the only thing she could afford were like hot dogs, eggs, and she couldn't afford things like pork chops or ham or beef or hamburger meat, those types of things. because it was too expensive for her. So when we're counseling patients on their diet, we really need to be aware of their income and, what food is available to them. Next slide, please. The first thing that we need to be aware of for obese patients is equipment considerations. In our office, we have oversized chairs. The chairs that aren't oversized actually does not have sides on them, so that people's pants and stuff can go across the sides. The other thing, wheelchairs. We've had to get scales that accommodate people up to 750 pounds. I remember when I first came back to South Carolina, we had scales, I think, that went to 350. And it was a rare patient that we had to send to the loading dock to be weighed. But now it is very common to see people 350, 400, 450 pounds. So you must get scales that will accommodate these individuals. The other thing that you shouldn't have in your office is commodes that are tied to the wall and not have a foot on the floor. The ones that are tied to the wall don't support as much weight, and you'll end up spending a lot of money in repairs. Obviously, gurneys need to be able to accommodate people 500 to 700 pounds. And then tables, okay? We only have one examining room table that individuals can that have a BMI of 50 or greater that can sit on. Our ultrasound tables, we don't have any that can accommodate anybody that's over 500 pounds. We have to take them into the examining room table, and then we can't get the ultrasound in there, so we have to use a smaller ultrasound, which ends up stacking the problems. And obviously the labor and delivery, the postpartum beds, and the operating room bed. We used to just borrow the OR bed from the bariatric surgery team, but now we have our own beds that go up to 1,000 pounds. These beds also come with extenders on the side that you can use if the patient's body habitus requires that. It's just difficult to operate when you're reaching much farther across the patient than you are used to. Next slide. So let's just review the pregnancy complications. First of all, there is an increased risk of congenital anomalies in obese patients. And the more obese patients are, the more likely they are to have anomalies. The two that we see the most frequent are neural tube defects and cardiovascular abnormalities. There is one anomaly that obesity is protective of, and that is gastroschisis. There's a huge reduction in the amount of gastroschisis in obese women compared to non-obese women. Next slide. So on the left-hand side is the body mass index. The middle column is the standard sonography, the detection of fetal anomalies. This is just like your routine scans in offices, and then targeted scans of different patients with obesity. Now, if you look at patients who have a class 3 obesity, 40, BMI of 40 or more, standard sonography picks up less than 25% of their anomalies. And even in a MFM's office, we still miss 25% of anomalies because you cannot change physics. Okay, you can try and you can make changes to your settings and stuff and use different probes. But the bottom line, you cannot change physics. I had the fortune of having dinner with Dolores Pretorius, who has, she's a radiologist who has spent her life studying high-risk ultrasounds in pregnancy. And I asked her, how many times do you recommend that we bring patients back? Because if you send us a patient with a BMI greater than 50, almost always we bring them back for a growth ultrasound in 4 to 6 weeks because we try to complete the anatomy. And I can tell you, sometimes we can't complete the anatomy in 3 scans. And at 3 scans, the first one and the 2 follow-ups, if we don't have the complete anatomy, and I don't think I'll be able to see it better, then I don't bring the patient back to our office for repeat scan. Now, Dolores says that this is acceptable nationwide, and that's exactly what UCSD does. But you will see some other people, like our junior partners, they'll follow up a patient till she delivers, trying to get the anatomy. Now, there's a difference between documenting normal anatomy and having a suspicion. So that, I can say this anatomy is normal, but if I'm suspicious of a problem, I just can't see it well enough to say what it is, of the heart or whatever, I will bring those individuals back more than 3 times. The other issue that we are all aware of probably is that cell-free screening test, cell-free DNA test requires a minimum fetal fraction. Usually they like 4% or more, but some companies will do it at 2 to 4%. Now, the normal amount of fraction they get is 10%. And anytime you get a cell-free screening test that's a failure to report, there is an increased risk of anomalies in those individuals. And so they recommend that they get genetic counseling. With obese patients, you have a much smaller fetal fraction, and up to 10% of women who weigh over 250 pounds will have less than the minimal fetal fraction that can be reported out. So just be aware that it's a problem. The other thing is MSAFPs, people say, well, I won't do a cell-free screen in low-risk patients, I'll just do the quad screen. Well, you have to understand, particularly the MSAFP is not as accurate in patients who weigh more than 250 pounds. Next slide, please. So the antepartum complications, there are higher incidence of cardiac dysfunction, proteinuria, chronic renal disease, sleep apnea, non-alcoholic fatty liver disease, often you will see the liver enzymes just slightly elevated in these individuals, usually somewhere from 4 to 40 to 80. And so I almost always get a set of a CMP on obese individuals to basically check for liver disease and kidney disease. Now, gestational diabetes, I will say that basically we screen people early in pregnancy, less than 12 weeks, and then at 24 to 28 weeks. And really what we're looking for is undiagnosed type 2 instead of just gestational diabetes. Now, you can choose to basically use a hemoglobin A1C, or you can choose to do a 1 hour and a 3 hour if it's abnormal. If you get an abnormal 1 hour and then a normal 3 hour, when they get to 24 to 28 weeks, please don't repeat their 1 hour because it's going to be abnormal again. Just go straight to their 3 hour to see if they meet the criteria then. If people, up until the last year, I would say, or actually the last 5 months, I would say to you that I would screen everybody with a 1 hour and then go to 3 hour. But if they're not a frank type 2 diabetic, then it doesn't improve outcomes to detect GDM early. So now I am happy just screening with a hemoglobin A1C. And if it's greater than 6, it's actually 5.8. If it's greater than, they have glucose intolerance. So they're going to have some issues during pregnancy. What I would do is I would counsel them on their diet and stuff, and then rescreen them with a 1 hour and a 3 hour at 24 to 28 weeks. There's also an increased risk of preeclampsia, and this is actually weight dependent. For every BMI of 10, there is a linear relationship of the onset of preeclampsia. And finally, there is an increased risk of stillbirth. Next slide. So the absolute risk of a stillbirth, looking at the total BMIs of 20, 25, and 30, you can see increases, either the fetal death increases significantly and stillbirth increases significantly. And if y'all like me, sometimes you have to go back and think, well, what's the difference between a fetal death and a stillbirth? And a fetal death can be 18, 20, 22 weeks, whereas a stillbirth is greater than 28 weeks. Next slide, please. And so ACOG and others have recommended antenatal testing, or they say you may perform it. And for a BMI greater than 35 and less than 40, they recommend weekly testing starting around 37 weeks. I'll be honest with you, we do not do this. We wait until the patient is greater than 40 weeks, a BMI of 40 or greater, and we usually start them between 34 and 37 weeks, and it's a once a week NST. The reason that we do this, if we tested everybody between 30, a BMI of 30 and 40, it basically would inundate our system and we couldn't provide the care. Next slide. I basically talk with every patient with a BMI of greater than 25 about weight gain. And people who are overweight, it's recommended that they gain 15 to 25 pounds for the total pregnancy based on the Institution of Medicine criteria. But obese individuals, it's recommended they gain 11 to 20 pounds. Now, I will be honest with you. I actually go on the low side. I tell obese patients that they shouldn't gain more than 15 pounds during their pregnancy, because sometimes, you know, I remind them at each visit how much they are gaining. And I think if you use the lower side, it sets a lower standard in the patient's mind. And so that's why I do this, but you can counsel 11 to 20 pounds. I just remind them the more that, the more you gain, the more you're going to have to lose postpartum to get back to your baseline weight. Next slide. So interpartum, obese women, they have longer labors for sure. There's an increased risk of cesarean section. And a lot of these women have medical comorbidities, and we end up inducing them. So is it the obesity, the induction, the medical comorbidities, all of the above that increases our cesarean section rate? I don't know the answer to that. But if you got a BMI greater than 50, right out the door, your risk of getting a C-section, I'm sorry, is about 80%. Obese women also need to see anesthesia when they present to labor and delivery. And the reason they need to see that is because it's very difficult to get a spinal or epidural in these women. And sometimes they have to go to sleep in an emergency and their airway is not the best. So we all know that obesity leads to increased risk of complications at surgery. You can consider increasing your dose of antibiotics. And like if you give Ancef at the time of your C-section, you know, we usually give 2 grams. Normally we can go up to 3 grams on obese individuals. And I will just say right up front, this is very controversial because we don't know if 3 grams actually increases the level enough to actually kill the bacteria. And therefore, I actually think it's something we should study more to see if we should even go up to 4 grams of ceftriaxone. But right now, we're only using 3. And if your hospital is not using more, you're also justified for that. I would say avoid using vertical skin incisions if you can. Sometimes you cannot get around it. If you use a vertical skin incision, it is more difficult to do a low transverse C-section than it is a low vertical. So when we use a vertical skin incision, we actually have a higher incidence of low vertical C-sections. You know, you can go under the pannus. You can actually tape the pannus up and go underneath it. And the other thing I will tell you is we give these individuals chlorhexidine to wash with the week before surgery. Also, if your skin incision or your subcutaneous tissue is greater than 2 centimeters, please do a subcuticular stitch. You can do interrupted or continuous, it doesn't matter. And then please don't use drains in the subcutaneous tissue. That increases your risk of infection. Next slide. So Barry has taught with us extensively about doing DVT prophylaxis in individuals. So please do not forget this in your postpartum orders. And last but not least, we need to really encourage weight loss. I tell every one of my patients that are overweight, advice is like castor oil. It's easy to give and hard to take, because if it was easy to lose weight, everybody in America would not, nobody in America would be overweight. Can you imagine just going down to the grocery store and getting a 50-pound bag of dog food and carrying that around everywhere you go all day long? I mean, you would be so tired. Well, obese individuals, that's essentially what they're doing. Some women are carrying around 25 pounds, and then some women are carrying around 150 pounds extra every day. And believe me, they don't want this more than they don't wake up on the morning and say, tomorrow I want to be 150 pounds overweight. This is a gradual pattern that happens. There's multiple reasons. But in the Medicaid expansion, I would like to encourage people to get these patients in to see counselors regarding weight loss, and especially dietitians, and especially if they have any comorbidities, because it will truly expand their life, their life expectancy. And you know, the University of Colorado actually has talked about, they actually follow women who have lost weight, and or people who've lost weight and kept it off. And there were 3 things that they did. 1, they ate breakfast. 2, they weighed at a regular interval. You can weigh once a month, once every other week, whatever you want. And then the 3rd thing, they exercised. And that is important. Patricia, you have your hand up. How may I help you?